Okay, well look, thank you so much for inviting me, second year in a row, and it's such a pleasure to be here. I feel like a bit of an outsider here really, but for the people that I've connected with so far, and in the last 2 days, you've made me feel really welcome, so thank you. It's a pleasure to be here, and I hope I can, in the next few minutes, share my passion, and hopefully we can look at how I might engage with you guys to achieve some of the goals of the National Respiratory Strategy. So, without further ado, oh, hold on, I'm in control here, aren't I? Okay, so how am I here? That's the first thing I want to go through is how do I come to be here standing in front of you? I don't have a medical background, but what I do have is 40 years of asthma. And so I was diagnosed with asthma at the age of 2. And for 40 years I suffered from asthma, and I can remember probably at the age of 4 or 5, my doctor, who was a brilliant doctor, he was one of those doctors that really looks into your eyes, looks, depresses the tongue, really gives you a thorough looking over. And he used to call me Wheeziana, and he would pop me on my back and he'd have me doing tummy balloons. And, he was trying to get my diaphragm working. And he really had it right, in many respects. The one thing he didn't do in all that intervention was look at how much I was breathing. And so what happened to me, my asthma over the years, I was an early adopter of asthma medications, and I suppose by the 80s I was onto daily inhaled corticosteroids, and managed the asthma throughout my life that way with, some pretty nasty exacerbations that would put me in hospital from time to time. But in the year 2000, I got really sick, and after 3 hospitalizations, I thought, I've got to do something. And that's when I did a little breathing course that basically helped me shift the way I breathe and helped me better manage my asthma. So what I'm going to share with you over the next 40 minutes, I think that's what I've got, is to show you what I learned on that course and how I've adapted it and how I help other people achieve similar results to me. And up there, that's the book. Chapter 2 of that book is all about my journey. So if you want a cure for insomnia, get that book. It's still available, I think. Can everyone hear me okay? Okay, yep. Okay, so what I'm going to cover, we're going to look at what is functional and dysfunctional breathing. We're going to look at the signs and symptoms of dysfunctional breathing. And my focus is going to be on breathing, obviously. Some of the consequences of dysfunctional breathing, and something that Alistair touched on in his wonderful presentation earlier about craniofacial changes and how they may affect our breathing. Then what we're going to do is I'm going to give you some simple guidelines of how you can actually assess dysfunctional breathing in your own practice, and maybe some simple steps that you'll be able to use to help better manage it. Okay, so we'll start off. What is a functional breathing pattern? We might as well start from this point. So, a functional breathing pattern is breathing in and out through the nose. Okay? Now that's not just at rest, but that's during, moderate physical exercise and of course when you're sleeping. Okay, so we always say to kids that noses are for breathing, mouths are for eating, drinking and talking. Okay, don't mix it up. Okay, so the breathing should be diaphragmatic, okay? 80% of your breathing effort should be diaphragmatic at rest. And the breathing rate, about 8 to 12 breaths a minute. Now, you can't measure your own breathing rate, by the way, but if you want to, you can measure someone else's breathing rate when they're unaware of it, but don't ever try to measure your own. You're always going to underestimate, in my experience. Oh, except for children, they overestimate. Okay, so the appearance of the breathing, it should be just slight and gentle. And even though probably standing in front of you guys and feeling a little bit nervous, I shouldn't be hyperventilating. If I was, I'd probably have to sit down and compose myself. Okay, and people's breathing, they shouldn't, it should be something that's running in the background. They shouldn't really be feeling their breathing. They shouldn't really be aware of it at all. And it should be regular, smooth and rhythmic, at rest. And of course, it should be inaudible. And the one on the bottom, we're going to look at that one a little bit later when Erin's going to come and help me, and we're going to do a little assessment. Okay, dysfunctional breathing. Okay, mouth breathing or heavy nose breathing, and more thoracic dominance. So you can see the chest and the shoulders moving. It would be noticeable. Breathing more than 14 breaths a minute. And again, the breathing is more obvious. You can actually, it's very obvious breathing. Now, instead of a nice rhythmic breathing pattern, it's punctuated by things like snorts, sniffs, yawns, gasps, maybe the way we speak. Now, again, even though I have to be a little animated up here, if you notice the way I speak, hopefully I'm pulling this off, it's slightly different than the way most people might speak. So just see if you can pick up what I'm doing. Okay, and again, the breathing is, it's audible if we have a dysfunctional breathing pattern. Okay, so what kind of things would you look for? The obvious one is mouth breathing. The reason I've got this image, do you think of all the girls that grow up with this little mouth breathing doll as a role model? And you wonder what influence this has on their breathing pattern later in life. So mouth breathing, either conscious or unconsciously. Upper chest breathing. Audible breathing. Frequent yawning. These are the kind of things you could look for, in your practice. Frequent sighing. People just sigh for absolutely no reason. Or just a little sniffing and snorting. And just any kind of obvious sign of the breathing. Catch-up breaths, that's another one. And large inhalations through the mouth when speaking. Now, in normal general practice, we would look at things like temperature, pulse, and blood pressure, but how often would we look at the breathing? How often would we actually, check that? And we know that traditionally in nursing, it was TPR. You agree with me? It was with temperature, pulse, respiration. Some people told me this is coming back into practice now. I don't know if that's true. Okay, so what is let's define hyperventilation. Hyperventilation is just breathing more than you need to breathe for that metabolic requirement. Okay, many of us are probably quite adept at picking up acute hyperventilation, but like for example when someone's having a panic attack, but not so much what we call that background chronic hyperventilation or chronic hyperventilation syndrome. Okay, now we have a look at here. This is a wonderful example of a recovery from fight or flight. Now look how quickly that guy recovers. Now that's a normal... Okay, so what happens during fight or flight? We'll focus on the breathing. If that was you, your breathing rate would get faster. You'd take bigger breaths. You'd be mouth breathing. You'd be upper chest breathing. You would have this irregular breathing pattern. That's perfectly normal for fight or flight. But what happens when the stresses become prolonged, as they do in our modern society? So what we're seeing is that people are existing in a state of, I'm sure you're probably familiar with the term sympathetic dominance. So they're day in, day out on the state of sympathetic dominance, and the breathing is following. And once that stress is prolonged, that over-breathing becomes the norm. And even if the stress is reduced, the over-breathing pattern can become the norm. So we're looking at there's a whole range of possibilities in there, and I won't dwell on that except to say that we're probably all familiar that life is getting a little bit more stressful for people, and the way they're coping with that stress is changing. And I like to quote this study that this could use a lot more data, but what you can glean from this is that breathing volumes have doubled in 50 years, and no one's talking about this. If you look at old medical textbooks, they talk about, I think it's about, is it 5 to 6 litres of air a minute's the norm, and the modern textbooks are saying around 9 litres of air, up say 6 to 9 litres of air a minute is the norm. Okay, so what's wrong with breathing more air? Well, can everyone see that? The thing to look at here is the little green patch there. That's carbon dioxide. In the air you're breathing right now, there's about 0.03% of the air is carbon dioxide. And in a healthy person's lungs, there should be about 6.5% carbon dioxide. And one way to think of your lungs, or one of the primary functions of the lung, is to mix the air you're breathing out with the air that you're breathing in. So essentially, your body is breathing this life-giving mix that's got a certain level of carbon dioxide. And of course, if the mouth is hanging open, and we're not breathing through the nose, potentially, and if we're over-breathing, potentially the CO2 levels can drop. So, okay, so what's wrong with that? Well, Christian Bohr, 1904, whoops, that wasn't supposed to happen. Anyway, essentially, he was able to show that when carbon dioxide levels dropped, the pH of the blood went up and hemoglobin had a greater affinity for oxygen. And so it can result in a state known as respiratory alkalosis, where the oxygen's actually stuck in the blood, if you like. And for example, if you're doing pulse oximetry in your clinic, and I use these things regularly, if you've got someone that's 99 or more, they're probably over-breathing. It's one little symptom. And okay, and what about, there's other factors too. Carbon dioxide is a smooth muscle relaxant. Now we have smooth muscle wrapped around every hollow space in our body. And when I ask kids that, they say head. They assume that their head is a hollow space. Mine feels a little bit hollow right now. So if you consider that carbon dioxide is a smooth muscle relaxant, if carbon dioxide levels in the body drop, think of bronchoconstriction in asthma. Think of nasal congestion. We have smooth muscle around the sinus areas in the nasal passages. Cardiovascular. If we're over-breathing, and I just throw this in there, snoring is over-breathing. If we're snoring, we're over-breathing. If we're over-breathing and the carbon dioxide levels drop, potentially you can get spasming of smooth muscle in the blood vessels, and a clear potential link to primary hypertension. Just simple things like, someone with cold hands and feet is a clear giveaway there. Just dropping through that, just to the urinary tract. So many of my clients come to me and they say, oh, I can't get through the night without 2 or 3 trips to the bathroom. Think about that smooth muscle wrapped around the bladder. Now, there's more to it than that, but I just wanted to give you some insights. That if you're over-breathing in your sleep, that smooth muscle is causing spasming around the bladder, and that can, increase the need to urinate. And of course, for kids, I'll just stop that for a moment. And of course, in kids, they might wet the bed. And I have a lot of kids in my clinic. We help them. It's not what they come to see me for, but the mums come and say, hey, they've stopped wetting the bed. Okay, so let's have a look and see what deep breathing can do. And some of you may have already seen this before. Now, what she's doing is, obviously she's deep breathing, she's sucking in air, and it's reducing the CO2 levels in her airways and blood. And if anyone ever thought that deep breathing is good for you, watch what happens now. And you'll probably already know what's going to happen. Okay, so if anyone's going to tell you that deep breathing is beneficial, just show them that video. And here's an MRI scan giving you an idea what is happening. This is a functional MRI scan showing normal oxygen levels. This is in cerebral blood vessels. And the one on your right is the same brain after 1 minute of hyperventilation, pretty much what that little girl was doing there, cutting oxygen supply to the brain by 40%. So if you consider that snoring is over-breathing, and think of what that might be doing to someone with sleep apnea, if repeated episodes throughout the night for uncontrolled sleep apnea, that they are, going hypoxic, every time they go through one of those cycles. And many of you will be familiar with some of the studies recently linking sleep apnea with Alzheimer's, which I think Alistair may have touched on earlier. So, if you're over-breathing all day long, it can lead to symptoms. And I just show you that slide very quickly because these are the kind of, in my clinic in Freeman's Bay, I've seen over 8,500 people now since 2001. And, these are the kind of things I'm getting referrals for. So, and these are the kind of disorders I can help people with. Now, I don't have time to go through all of these different ones, but I just touch on just 3. And an interesting study here showing that males diagnosed with sleep apnea were breathing 950 minute volumes and 15 litres of air per minute. This is during the day. And I think, as Alistair said again, sleep apnea is not something you look at, it's not just the nighttime breathing you've got to look at, it's overall. And when I see people with sleep apnea in my clinic, there are many parameters we could see that would be very good predictors of sleep apnea. Again, the relationship between hyperventilation and asthma. And in the first trial that was done of the Potato method in the West, was published in the Medical Journal of Australia, they showed that people classically diagnosed with asthma were breathing, on average, 15 litres of air per minute at the start of that trial, when the normal would be less than 10. And there's many studies showing that hyperventilation is common in people with asthma, and also that loss of carbon dioxide during hyperventilation can trigger bronchoconstriction. By the way, any of the references that I've quoted today will be available on the Asthma Foundation website. And we're going to use this little device called a Capno. I'll show you this thing a little bit later. But this is just a recent study coming out that was actually showing that Capno-assisted training of people with asthma, essentially helping them to override their hyperventilation, showed significant outcomes in reduction of symptoms and need for medication. And again, not going to dwell on this except to say there's about 10 studies have been done worldwide on the Potato method so far. And these studies show similar findings. They're small studies. They go from about 38 to about 100 subjects. So, there's definitely need for bigger studies. But 2 small studies were done here in New Zealand at Gisborne Hospital as well. And you can see, these are significant results that we really need to look at. I just show you that one really quickly. One of my heroes, Jim Bartley, is an ENT surgeon in Auckland, and he does refer clients to me from time to time. And this paper appeared in the American Journal of Rhinology, where he was able to, he was suggesting that people with recurrent nasal congestion consider hyperventilation syndrome in the diagnosis, particularly where surgery had failed to show any improvements. And also, again, just a couple studies showing that slow breathing was able to reduce blood pressure. And I think this may be one factor, with one thing that CPAP does, when it's applied, it's effective. It's providing resistance to the breathing and effectively helping to slow the breathing down. So this may be an important factor in how perhaps CPAP therapy helps to lower blood pressure. One other issue, in terms of the inflammation that we often see associated with things like asthma and allergic rhinitis, we know that overbreathing can produce a state of hypercapnia, and hypercapnia is low carbon or carbon dioxide deficit, and hypercapnia can trigger mast cells to release histamine. And isn't it interesting that so often we see, that I think a specialist once referred to it as the Holy Trinity of asthma, hay fever, and eczema in the same people. And that was me. I had chronic asthma, I had daily symptoms of hay fever, and I used to use hydrocortisone creams every day for the eczema that I suffered from, and I don't now. Okay, now another little factor we should, again, Alistair touched on this too, is how mouth breathing and low tongue posture affect craniofacial development. We're looking at starting from very young kids. The tongue should sit in the roof of the mouth with the tip of the tongue just touching behind the top teeth. So your tongue's sitting up here in the roof of the mouth. Tongue's a very strong muscle, and it will apply pressure to keep the palate broad, and of course the lips are a counter pressure to sort of, the teeth are sitting in that neutral position. If we're mouth breathing and the tongue drops into the floor of the mouth, into the maxilla, that pressure is gone, and the face has a chance to sort of develop longitudinally. And here's an example. You'll see the one on the left is a nice, good maxilla with nice, evenly spaced dentition, broad palate. And it's one of my clients there, the narrow arches. There's no room for the tongue now in the roof of the mouth. So the tongue sits in the floor of the mouth, and you develop what's called long face syndrome. And I'm a classic example because I mouth breathed for 40 years. And there you'll see on the left-hand side, there's a CT scan showing, there's someone who's a nasal breather. You see the tongue sitting right up there, hard up into the upper palate. See how the palate's nice and broad. Good straight nasal septum. Some of you who are more expert than me in this field might say those turbinates look a little bit inflamed, but the dentist that refer clients to me in Auckland provided that and said that's about as good as it gets in Auckland. Everyone's got slightly inflamed turbinates and sinuses. Compare that to the one on the right. It's not photoshopped. Look how narrow that is. And one of the consequences you'll see that very high hard palate? And that has caused the deviated septum. As that rides up and the septum starts to bend, and you can see the constriction of the nasal passages there. So what we need to take away from this is that it's this mouth breathing habit, the open mouth posture, the low tongue posture, that is driving the changes in the craniofacial shape that effectively, potentially leading to narrowing of the airway, the crooked teeth. Alistair mentioned the receding chin, which is definitely a marker in obstructive sleep apnea. And the chance of issues coming on from that. Okay, now what we're going to do now is I'm going to just run through, give you a little bit of a taste of what I would do in a typical breathing assessment, and then I'm just going to finish off with showing you a few things that we can do. So the kind of things I would be looking for is when someone comes into my clinic, the first thing I've done is measure their breathing rate. I've looked at things like rhythm, whether they're taking big gasps of air when they speak, whether they're sniffing, snorting, yawning, so forth, taking a mental note of all of these things. And looking at the mechanics where they're breathing up here or they're breathing from the diaphragm, and also checking things like posture. Now, what I also do is I'll generally we'll take a pulse, we'll do some pulse oximetry, and then we'll do a capno assessment, which Erin's just kindly offered. I'll give you a yell in a moment, Erin. We should be ready to go shortly. Okay, what I thought I'd do, just to give you a taste of this, I'll get you all to take your pulse, and you can sort of, pretend you're clients of mine for a moment, okay? So I'm sure you're all very familiar with that. And we'll take this pulse. Because we're very busy and important people, we'll only do it for 15 seconds. And I'll count 15 seconds, and then you can multiply. Actually, no, we'll do it for 30 seconds, and you can multiply by 2. That's easier. Okay, so if everyone finds your pulse. Okay. All right, so you count the number of beats from when I say start to when I say stop. Start. Stop. Okay, so just multiply that by 2 and write that down somewhere, because what we're going to do is I'm going to also show you a breathing exercise, and we'll look at a before and after. Pulse is sometimes a useful indicator. Okay, we're going to have a little bit of fun here now. We're going to do a little breath hold test. Now again, I use this as part of my diagnosis, is it's the length of time someone can hold their breath, and it's a comfortable breath hold. Now, as some of you may know, or probably most of you know, the breathing reflex is controlled by the levels of carbon dioxide in the arterial blood, okay, and the cerebral spinal fluid. So it's carbon dioxide that controls the rate and depth of breathing, not need for oxygen. So this is kind of a useful indicator, and what I'm going to do is I'm just going to say to you, take a normal breath in and out through the nose, and then I want you to hold very lightly, and I'll be counting the seconds, and then you release at the first urge to breathe, okay, the very first desire to breathe. It's a comfortable breath hold, and again, write that down, and I'll show you what that means. And then once we've done that, I'll get Erin up here, and we'll do a little capno session, and we'll see what I can show you with that. Any questions before we do? Okay. Okay, you ready? Actually, I better check this. It's zeroed. Yes, okay. Take a normal breath in through the nose, normal breath out through the nose, and hold. 2, 4, 6, 8, 10, 12, 14. Oh, I should have said keep mouths closed. 16, 18, 20, 22, 24, 26, 28. Anyone that's still going is a show off. 30, 32, 34, 36. If you're still going, I'll stop you now, but well done if you got that far. Okay. Thank you. Now, bear in mind, what I'm about to show you is a guide only. You shouldn't take too much from this, except it's a useful guide for people to see where they might plot on the scale. So, on this chart, we're looking at breath hold time, and I should say this is not exclusive to Buteyko practitioners. Breath hold times are used in medicine. But this work is based on the work of Constantine Buteyko, and what's really interesting for me is that I used this. This is my only real diagnosis, well, apart from all the other parameters I measure, but I didn't have any way of testing this until I got the Capno trainer, and I'm surprised how close the fit is since I've started using the Capno, which I'll explain in a moment. So, breath hold time on the left-hand side, and what it means in terms of our predicted arterial carbon dioxide. And if we come across what that means in terms of the number of litres we're potentially breathing at rest per minute, and what that might mean in terms of our breathing. Now, breathing is really the new black. You'll hear more and more and more about breathing, and it's really good because at the Asthma Foundation, this plays right into your hands. People are talking about breathing. I can't believe the number of people that call my clinic now and say, I've got a problem with my breathing and I need to see you. And that didn't happen at first. They used to come to me for asthma, chronic cough, hay fever, sleep apnea, snoring, but now a lot of people are saying breathing. So we would suggest that maybe 80% of the population probably need help with their breathing. So don't be discouraged if you see yourself kind of low on the scale there after that little test. Okay. I think, oh no, we'll go back one. So Erin, if you come up now, we'll see if we can get this thing working. Hi. Now, probably if you just, I don't know, just maybe sit there. I was going to get one of those other chairs up there, but we probably don't need it. Do you know how to put one of those things on?
No.
Okay, so Erin's going to, she's very kindly agreed to be a guinea pig, and what she's going to do, she's going to put this little nasal cannula on, and unlike the nasal cannulas you'll see for oxygen therapy, this one, well done, you've done this before, yeah.
Put one on my nana before, but I can't remember.
Okay, so it goes in the nostrils like that. Oh, here, I'll take all this stuff, and then you flick these in around your ears to hold it in place. Yep, you got it.
Ready?
Cool, here we go.
Oh, well, cool. I spilled chocolate down my top.
Hopefully this will come up on the screen. Do I have to do something here, Brendan, to get it to go on? I think I probably do. Sorry, I saw you do it yesterday, but I can't remember how you did it. Ah, there you go. what we've got to do, you're probably better at this than me. I just want to basically hit that. We want to get right there. Hit that. Right there. That's it. That should do it. Perfect. Okay, we're away. Now, you just breathe your normal, natural way, okay? And it's probably best not even looking at that at all. Okay, and I'll see if I can interpret what's happening. You'll come over here. It's too far away. Okay, so look at the way that Erin's breathing and just carry on what you're doing. It's absolutely perfect. There we go. That's more like it. Okay. Okay, so the up is the out breath, the down is the in breath, and it's all over the show right now.
Welcome to my world.
Okay, what I'll get you to do, see if you can just close your mouth. Okay, all right, and we'll just see what happens. So just breathing normally through the nose. Okay, there we go. That was an interesting demonstration of how mouth breathing is not really ideal, because as soon as we're breathing through our mouth, the CO2 levels drop. Now, what we're looking here, I should say the scale there, see that scale, the axis there, the x-axis, that is carbon dioxide or N-tidal carbon dioxide, and that's calibrated to give us a rough estimate of what's actually happening in the arterial blood and in alveoli. We've got a nice breathing pattern here. Obviously, because Erin knows her breathing is being assessed, so she is shifting it accordingly. So it's hard not to. If you know your breathing's been assessed, you'll be certainly shifting. And this is not looking too bad. Can you remember back to that slide we had of showing breath hold times? And you'll see that purple line, if you like, there. We want to be breathing above that threshold. So let's just see if we can get there, Erin. So what I'm going to do is I'm going to give you a little bit of a guided breathing session, and we'll see. It's not ideal, this chair, but we'll see. Maybe push back a little bit so you're really comfortable. Okay, so nice upright posture, shoulders relaxed. I want you to get the sense of your breathing down here into the belly. Okay. Now what I want you to do is get a nice, easy, rhythmic breathing pattern. And just see if you can slow your breathing down a little bit, and even just feeling a slight discomfort as though you're not quite breathing as much as you'd like to breathe, and we'll just see what happens here. What we'll be trying to do is seeing if we can get up to that threshold, okay? We're not doing bad. Yeah. Ooh, keep going, keep going. Oh, beautiful. Okay. This is good. A little bit of, yeah. If you get, oh, beautiful. That's great.
Still with my mouth shut, right?
Yeah, mouth shut. Just for a moment more. Okay, so just giving you is kind of like just a little snapshot of what we're doing. So with guided breathing exercises designed to help slow and normalize that breathing pattern, because we make the assumption that Erin, because Erin told me she has asthma, so we make the assumption there is a dysfunctional breathing pattern, and we have an over-breathing pattern. So what we're doing here is we're doing a guided breathing session to just slow the breathing down and just gently raising CO2 levels. And you can see that happening there really nicely. Now, just for contrast, go back to your old mouth breathing habit and let's see what happens. By the way, how did you feel after that? Any different? Same?
No, I feel the same, to be honest.
Okay, yeah. See the difference? Yeah. Now, what you have to bear in mind is there's still some traffic through the nasal passages, and what this thing is measuring is ratios of carbon dioxide to other gases. So what it demonstrates quite nicely is how mouth breathing drops that CO2 out. Now we'll just try, I don't imagine you probably snore, I can't imagine that you snore, but you're pretty good, you're a good actor, so can you give us a little simulated snore, and let's see what happens with a simulated snore.
After we get sleep, it's great.
I'll make the sounds. Okay, again, can you see what's happening there? Okay, so imagine if you're doing that night after night after night. What's happening with your breathing? Brilliant, you've done an absolutely superb job. I should actually thank you so much. And that's yours to keep.
Oh,
Thank you. We don't reuse them, by the way, and we did use a clean one. Can we flick back to the other? Yeah, thank you, Brendan. Okay, thank you so much, Erin. That was great. Whoops, what happened there? We'll pause for a moment to get it back. So, beautiful. Now, can anyone give me a time check? Just let me know how much time I've actually got. Almost out of time, okay. What I was going to do, take you through a guided breathing, whoops, we've gone back to the beginning. Yeah, I was going to take you through a guided breathing session. Are you able to take me through to that slide, Brendan? Because I kind of got knocked out there. Go right through. Yeah, so I was going to take you through a guided breathing session, but you never know with these things how long they're going to take, so I don't seem to be having much control with this thing. I just want to give you some actionable guidelines to take home to finish off. Brendan, oh, okay. Okay, so we know with stressful breathing, faster, bigger, more mouth breathing. So the idea with is to get the breathing, when we're doing these guided sessions, is relax, slow it down, reduce the breathing volume, get it nasal, get it diaphragmatic, and smooth it out a little bit. We won't do this right now. We don't really have time. Oops, we seem to be going... Why are we going? Oh, it's upside down. Oh, okay. That's what happened. Sorry. This is some of the breathing awareness things we were going to do. Okay, so look, what I'll do to finish off with you, things you can do is look for open mouth posture and really include this as part of your diagnosis. If you see an open mouth posture, we have an issue with the breathing. And you can advise them to close their mouth and just see how easy they find that. Look for upper chest movement at rest is another indicator. Look for things like yawning, sighing a lot. You know, if they're in your clinic and you see these things. Look for an irregular breathing pattern, sniffs, snorts, sighs, and so forth. Big gusts through the mouth when speaking, and any symptom that may be related to dysfunctional breathing that we've talked about. And there you go. So, keeping the mouth closed, breathe through the nose at all times, even during strenuous exercise. Tongue should sit in the roof of the mouth. You know, suppressing the urge to yawn, sigh, gasp, and if possible, suppressing the urge to cough. You know, it's those dry, hacking, habitual coughs that just provoke more inflammation than they resolve. Simple breathing exercise, just a little bit of diaphragmatic breathing exercises each day to sort of get that diaphragmatic breathing awareness happening. And something I would, devote a whole session to would just be looking at the kind of foods that we see as being inflammatory and congestion promoting. And it's interesting, in an earlier talk was talking about dairy not really being an issue. It's not what I find in my clinic, but I'm very, open on this one, and I'd like to see more research on that. So if I had a call to action in light of, I've had a review of the wonderful National Respiratory Strategy, what I'd really love to see is that screening for mouth breathing and other signs of dysfunctional breathing be incorporated into practice. So, and I do believe that this will really help in some of these aims. And I'm just going to leave you with that slide. I really do believe that we could have real positive outcomes in helping to reduce the burden of respiratory disorders in New Zealand by starting to incorporate some of these things. So look, thank you very much.
Yeah, gosh, thanks very much, Ken. I think all of us agree that, you know, the whole breathing thing now, of course, very rare. During this business now, you know, really important to think about that for our clients and how we're breathing. So thank you very much. Given us lots of food for thought. Thank you very much.
Thank you. Thank you very much. Okay.
Thank you.